did you have any other questions you wanted to bring up, or do you think we should talk about some cases, or what would be interesting to do?
Yeah, let's get into some case specifics. I think that would be useful to the to everybody sort of listening and watching here, because I think that's where the rubber meets the road comes into play, really.
For sure, for sure. Well, I actually am going to start off with one that you
Sure.
already sort of started to pitch to us, and that's that terrible gallbladder. Because I think as acute care surgeons, and especially when you think about the ambulatory setting, this is the one. This is the money shot. So I'm going to present a 54-year-old diabetic male who you take for a cholecystectomy for symptomatic cholelithiasis. And intraoperatively, he's found to have quite an intrahepatic gallbladder that's thickened and fibrotic. I'm sure you've never seen this case before.
I was just about to. I feel like I'm reliving my OR day yesterday. So thank you for the PTSD right now. That's great. So
Yeah. So after a difficult dissection, and you get, really great hemostasis to the best you can with electrocautery, but you've now got the raw surface of this liver bed, and it's oozing diffusely. So I just wanted to talk a little bit about THA selection for this case. And definitely, again, there's a lot of clinical factors and performance factors that we should consider. So I don't know if you want to go first and talk about what you'd be thinking about, and then I can give you my thoughts as well.
sure. So I'll start by, I think, dividing it into reality and then ideally what would happen with both of these. So in ideally, the cautery would take care of the surgical bleeding there. You've clipped your cystic artery. Maybe you've valsalvaed to make sure that the clips are in place and nothing is coming off and everything looks great. And then you ask for a topical hemostatic agent, whether that is a flowable or some Surgicel, to lay nicely in the gallbladder fossa. And then you pat the liver down and the patient wakes up and everybody goes on about their business there. I would say there are elements to the ideal situation in what we do, but in reality, what I feel like happens is we've got some annoying ooze, so we try the cautery. And then there's another spot of ooze, and then the person holding up the liver causes a little crack at the top because they're grabbing too hard, and then you have to control more bleeding. And then you maybe put the Surgicel down and then pat the liver and then lift it up, and there's still ooze. So you take that out, and then you try to put the flowable in, for an example, and lay that down. But then you irrigate, and now you're washing the flowable away because you didn't plan well. And now you've got to put more flowable in to stop that ooze. And you lift up again, and it's matted, and you've got to spread it out, and it's getting clumpy and clotty. But then luckily everything is stopped, and everything looks good, and you close up anyway. So I feel like in some ways, the ideal situation is having appropriate planning. And in reality, sometimes it's let me think about the steps before I glibly apply one of these to make sure, A, I have surgical bleeding control, but B, I'm not wasting what I'm putting in there and not just running roughshod over the operative scene before waking up and going on to the next case. Because liver ooze, and we'll talk about other cases, can be a real problem. And it is, I would say, easy to control if you're thoughtful about it there. So to summarize, my standard practice is, yes, I'll use what I have on hand, and I am both a flowable with Flow Seal or Tisseal and a Surgicel or Nunet kind of person. But I only do that if I really think it's a persistent problem. And that can be in Gestalt sometimes, but otherwise, those are my go-tos for that type of procedure.
Yeah, no, I couldn't agree more. And I think, it's interesting, when I was thinking about what kind of case would we discuss, I was thinking about how can I add all the information that a person would need or want to decide what kind of agent they're going to select. But it's a picture's worth 1,000 words. So I can describe this case to you for 20 minutes. But if you walked in the operating room and looked at the laparoscopic screen, and then you would maybe know what you wanted to go for, because it's not always not always describable. So I think just as a reminder for for discussion points, you want to think about clinical factors. This patient that we're talking about should have an intact coagulation system. So from that sense, they would potentially be a candidate for physical agents, and those are generally much cheaper. So if you have something like Surgicel that you can lay on the liver bed, and that can do the trick, then that might be your cheapest option. So I think it's worth considering. Again, this is going to potentially be a really irregular surface, depending on the shape of the gallbladder and really of the liver bed now that the gallbladder has been excised.
Right.
And so it may not be overly easy to apply that. And so you might end up wanting to go more with a flowable just because of
Right.
the ease of application. And again, this is laparoscopic surgery, so you have to think about what kind of applicator do I have? Am
Exactly.
I going to be able to put this on laparoscopically? And finally, you want to think about what kind of bleeding you have. So just taking out a gallbladder, you're generally going to have pretty mild ooze. But in this case, if you have an intrahepatic gallbladder, you really could have a pretty significant ooze from that liver bed. And you might want to think about a fibrin sealant the way that you would after a hepatectomy. So I think all of those things are important to consider. And there's never really one topical hemostatic agent that is the quote right answer. You kind of have to consider your factors and look at what you see and go with it.
Couldn't agree more with all those points. And I think as you alluded to there at the end, the type of bleeding you have, just from good clinical surgical practices, while these agents are extremely helpful adjuncts, looking at the scene there for a few minutes, it's not just an apply and sort of go, but it's actually making sure that in that time frame they're accomplishing what you want them to accomplish, and making sure that there's nothing else surgical that needs attending to before you conclude the case. Because again, these are taking care of that ooze in the patient who has an intact coagulation system, but will not take care of that surgical bleeding, just to drive home that point again.
Mm-hmm. For sure. For sure. What do you think? What kind of cases do you think would be interesting to discuss?
Sure. So again, keeping in the mindset of the acute care issue, and I guess either nowadays the inpatient or perhaps the outpatient setting, I feel like the difficult appy with that retroperitoneal dissection there, if it's stuck and matted and the patient's had several days of pain and here we are, can be a real problem, because that retroperitoneal ooze and that sort of amorphous space, if you will, is an issue. And you would think it's just an appy. We can solve this bleeding. This should not be an issue. But these can come back to bite you. And so I'd be curious to see how you approach that if you've encountered that. And I dare say you've had a few difficult appies in your experience
For
there,
sure.
as I know I have.
Yes, for sure. And I think that especially these retrocecal, when you finally get the appy out and it's high fives all around, but now
Right.
you've got this sort of just raw retroperitoneal surface, and it's angry. It's hyperemic and it's angry. And I think
Right.
we're used to that surface in trauma, but a lot of times it's going to be packing and it's going to be sort of a staged operation, which
Right.
really isn't a part of the equation for an appendectomy. So,
Right.
yeah, I think there's a lot of agents that can be useful there. And I go through the process sort of similarly to like what I was talking about with the gallbladder. And that is this patient, do they have an intact coagulation system? And if so, can I just use a physical powder? I like powders a lot. You can use something simple like Arista, or Surgicel has a powder on the market now that has some active agent in it. So I think that powders are nice because you can go over a large surface area, such as the retroperitoneum, like that, if you've completely mobilized the right colon to get that appy out.
Right.
And you can sort of control an even spread of those, and you can control how much you put in. So, like we were talking about earlier, you don't want to use more than you need.
Right.
So, I think those are reasons why I sort of lean towards that agent. But
I couldn't agree more. And I think your first comment of you sort of think about it similarly as the gallbladder. I think one of the main points is that a lot of these agents can be similarly applied in different situations, but it's knowing from experience and in talking with others how to read and interpret the bleeding situation before you in combination with the patient and clinical factors that you have worked up preoperatively to the best of your ability, including their coagulation and bleeding status, and knowing how much to use and where and when, and being precise and diligent with it. But knowing that this type of diffuse ooze, it can really happen anywhere, and then it's easy to apply these things to different situations, but still keeping in mind that every situation is different, as every surgeon well knows.
for sure, definitely. Yeah, no, I think that there's really there's no end to the discussion we could have in terms
Right.
of the advantages and disadvantages to each individual agent. But I wanted to just sort of review a couple points that I think are really, really important that
Yes.
everyone should sort of leave with. And I think one of them we've mentioned already, but can't say enough, and that is that topical hemostatic agents are not a replacement for good surgical technique. And I think whatever it is that you're going to use, you have to know that you did an operation that you can leave without using anything. And maybe you're going to get an even more meticulous hemostasis without any sort of postoperative ooze if you use the agent. But regardless, if you had not used the agent, you've done the sufficient and correct and complete operation. And I think that's the way that you have to think about it. That you got complete hemostasis without the agent. And I think, as we've talked about today, both clinical and performance factors should be considered when you're deciding exactly which hemostatic agent you want to use. There's a large number on the market. There's not necessarily one correct one. So you really have to weigh the advantages and disadvantages of each of them. Some examples: physical agents require an intact coagulation pathway. So if that's altered, then you need to steer away from those and towards some active agents. Bleeding near sensitive structures such as nerves, bones, those should steer you away from physical agents. And then if you have a really irregular surface, like we were talking about, powders and flowables, they lend themselves pretty nicely to those in terms
Yes.
of application. So I think those are some really important points. Is there anything you wanted to add?
I couldn't have said it better myself, and I think that's what everybody should take away from these is what we just said, that they're adjuncts, and knowing when and how to use them, while knowing that you have done the best operation you can so that you don't need these agents, but they are helpful to you at the end. Well, Megan, this was great to talk to you again today. I know we're both sorry that Dr. Ito couldn't be here, but I know we covered some really important points, both in the initial presentation and now. And I think we've done some good, hopefully spreading the word about how these agents can be impactful in somebody's surgical practice, because it's a topic that comes up every day. And so hopefully people have gained some good information from this, and have learned something from this presentation.
Yeah, thank you so much. And thank you everyone for joining us. I think it's really been a great presentation and discussion. And I think there's a lot of really important information that we can take back to our clinical practice. I'd like to thank Drs. Davis and Ito for joining me in today's panel discussion, and our virtual attendees for listening. We'd like to invite you all to take your post-test in order to claim your CME credits. You can find the link below the video. We'd also love to hear from all of you, so send us your questions by completing the evaluation survey, and check out our upcoming podcast series to hear our answers. Thank you.